Welcome to the all viewers and well-wishers of the world. The purpose of my lecture is learn the knowledge from the word and return the knowledge to the word. Motto of my life is learn, earn and return. As I have learned a lot, earned a lot, now it's a time to return a lot to the word. The topic of today is psoriasis. Psoriasis is a long-lasting, genetically programmed autoimmune inflammatory disease. Some refer it as immune-mediated inflammatory disease and not an autoimmune disease. It is non-contagious chronic skin condition that speed up the life cycle of the skin cells. It causes cell to build up rapidly on surface of the skin, so there are raised areas of the abnormal skin. The extra skin cells that form, these now form the scales and the red patches that are itchy and sometimes they are painful. It begins as a small scaling papule. Multiple papules coalesce and join together to form the scaling plaques. It occurs in scalp, elbow, arms and knees mostly, and it often comes and goes, means remission and relapse. Now one can see the scaly rash of the psoriasis, and it is very much prominent at the knee. The extensor surface of the knee is a very common and notorious site for that, and here one can see the skin with lot of scales. Now, psoriasis, the word is from the Greek meaning itching condition, and symptoms are red, purple on the darker skin, but otherwise these are red, these are itchy, scaly patches of the skin, and the complications are psoriatic arthritis. Usual onset seen in the adulthood, and duration is usually chronic and long term. Causes are genetic disease triggered by the environmental factors, and the diagnostic methods are based on the symptoms. Treatment is steroid cream, vitamin D3 cream, ultraviolet light, immunosuppressive drugs such as methotrexate, which is mostly used, and frequency of the disease is 2 to 4%. Now one can appreciate the plaque on the different body surfaces, as one can see on the extensor surface of the arm, the back of the chest, and on the leg, and on the other area of the skin. Now, history of the patient is that it was first described in the ancient Rome by the Cornelius Celsus. Greeks used the term lepra for the scaly skin conditions, and they used the term psora to describe the itchy skin conditions. It was known as Villan's lepra in 18th century, and leprosy have regular circular form of the patches, while the cirrhosis is always irregular patches. Villan identified two categories. One is leprosa grecorum and the psora leprosa. These were the two categories identified by the Villan. Now, Thomas Beckman differentiated it from the other skin diseases in 18th century's Fowler's solution, which contains a poisonous and carcinogenic arsenic compound, was used as the part of the treatment of this disease. Mercury, sulfur, iodine and phenol were also used. Coal tars were widely used with ultraviolet light radiation as a topical treatment in 19th century. Psoriatic arthritis cases were treated with the intravenously administered gold preparation as it was in the past for the rheumatoid arthritis. Now, epidemiology of the disease. Disease affects about 2 to 4% of the population and its rate varies according to the age, region and ethnicity. Men and women are equally affected. The disease begins at any age but usually in the adulthood. Reason is a combination of environmental and genetic factors both affect. It is more common in countries which are farther away from the equator, and it is more in the white European races, less in African, and it is rare in the Native American races. People with the inflammatory bowel disease such as Crohn's disease or the ulcerative colitis, they are at increased risk of having this disease. Now, coming to the causes of the disease, number one cause is injury to the skin. If there is any cut, bug bite, sunburn, it can trigger psoriatic skin changes at that spot, and that is known as Kobner phenomena. The number two cause is genetic. A genetic disease, positive family history, and it is triggered by the environmental factor. And if one twin has psoriasis, the other twin is 3 times more likely to be affected, and it is so seen more in identical twins than in non-identical twins. The major determinant is source 1, or it is called PSORS1, or source 1, which is located on chromosome 6 of the human being. The third cause is lifestyle, stress, changes in season and climate, hot water, smoking, and obesity is also one of the causes. Scratching the psoriasis skin, lesion, the skin dryness, excessive alcohol consumption, and decreased level of vitamin D is also included. Now, here one can see the psoriasis causes. These are medicine, skin trauma, alcohol, stress, obesity, genetic predisposition, infection, and endocrine disorder. So, number 4 factor of causes is HIV. It is more severe in people infected with HIV infection. So there is higher rate of psoriatic arthritis, and that is untreatable with conventional therapy in case of HIV infection. Number 5 cause is microbes. Psoriasis occurs after stuffed throat and by skin or gut colonization by the microbes with Staphylococcus aureus and Malassezia species and Candida albicans are notorious. Gutted psoriasis is triggered by a group A Streptococcus infection, which is responsible for tonsillitis or pharyngitis. Number 6 cause is drug induced, and the drugs notorious are beta blockers, lithium, antimalarials, non-steroidal anti-inflammatory drugs, terbinafine antifungal, and antihypertensive captopril. Calcium channel blockers, glyburide, interleukins, interferons, and statins are also sometimes said to be the causes. TNF inhibitors, infliximab or adalimumab are also the causative. Now, if you look at this causes of psoriasis, there is genetic, immunological, injury, infection, extreme temperature, drugs, and stress. And if you look at this diagram, stress, genetic tendency, drugs, food allergens, environmental allergens, and there are certain systemic diseases and skin trauma and infection. These are all going to alter the immunity of the person, and that leads to the psoriasis. So these are psoriasis multifactorial causes which are shown in a tree. Now, sign and symptoms of the disease are different for everyone. Patches are typically red, dry, itchy, and scaly. Patches are purple in darker skin color people, and psoriasis varies in severity from small localized patch to the complete body coverage by the scales of this disease. Red patches of skin covered with thick silvery scales that range from the few spots of dandruff-like scaling to the major eruptions that cover large area including the fingernails and the toenails also sometimes. These plaques are dry, cracked, can be itchy, burning or show soreness. Extensive psoriasis have negative effect on a patient's self-image and emotions as the patient is unable to show his or her psoriatic affected hands. Now, psoriasis symptom, as one can see, the red patches on the skin, small scaling spots, cracked skin, itching, and soreness, and the thickened nail and swollen and stiff joints are all the symptoms of psoriasis. Now, when the scale is peeled away, small bleeding points may appear. This condition is not contagious, appears as remission and relapse. Symptoms worsen during winter and with medication like beta blockers and non-steroidal anti-inflammatory drugs. Infection and psychological stress have a definite role. Psoriasis affecting the hands make it impossible to interact normally with the others, as I have already told you that these hands are just making the people shame and they are not interacting well with those hands. Specific medical signs include Auspitz sign, that is pinpoint bleeding when the scale is removed, and Koebner phenomena, that is psoriatic skin lesions induced by the trauma to the skin. Now, here one can see the areas which are involved by the scabies, that is scalp, face and ears are not involved, they are spared. Umbilicus is involved, genitalia and the knees. The red are the areas which are commonly involved, and here one can see the scalp, the elbow, the arms and the buttocks. These are mostly involved. And here one can see the most common site, the extensor surface of the arms and extensor surface of the legs, the nape of the neck and the back of the head and the hands. These are all very commonly involved. And here also one can see the arms and the armpit, that is the arm where the patches can be seen on the hand, on this surface, and the nails are also involved. Sometime you need to shake the tree of the friendships just to get rid of the rotten fluids. Because if you will shake, only the healthy fruits will attach to the tree, but the rottens will fall off. So get rid of your rotten fruits and friends. Now, severity of the disease. Mild psoriasis is shown by the percentage of the body surface area, that is BSA, and it is about 10% usually. Moderate to severe psoriasis, it is more than 10. And other parameters to measure the severity are: number one, are a psoriasis area severity index, that is called PASI or PASI, and a dermatology life quality index, that is abbreviated as DLQI. Moderate to severe psoriasis, then there is body surface area is more than 10, or PASI score is more than 10, and DLQI score is more than 10. In mild psoriasis, score is always less than 10. DLQI, that is Dermatology Life Quality Index, is a questionnaire with score from 0 to 30, and the answer of this question, one can say that the problem is moderate or severe. PASI is most widely used method with score from 0 to 72, again a questionnaire. It assesses severity of the lesions and the area affected. Now, one can see in case of the moderate involvement, there is 3 to 10% of the body surface area is affected, as one can see on the knee and on the front of the chest. But in case of the severe, more than 10% of the body surface area is affected, as one can see the arms, the legs, and the area one can assess that is definitely much more than this area, which is shown as red, and this red is more than 10% of the body surface area. Now, other way is psoriasis coverage and severity. In case of the mild, it is less than 3% of the body as psoriasis, as one can see the yellow area, and here there is moderate 3 to 10% of the body area, and in case of severe, one can see the more yellow area, that is more than 10% of the body is involved, and 1% is the surface area of the hand. So one can see the area involved, that is definitely many surface area of the hand. Now, what is the pathophysiology? The immune system reacting to the skin cells and white blood cells called T cells, neutrophils, these cause inflammatory process that leads to the psoriatic plaque in the skin. 3 genes in SORC1 locus are responsible, and these act on the corneodesmosin, a protein in the granular and the cornified layer of the epidermis. Initiation phase, with the skin trauma, there is infection or the drug leads to the activation of this immune system, and overactive T cells attack the healthy skin cells by mistake, and that trigger the increased production of the healthy skin cells. Immune cells move from the dermis to the epidermis, and they secrete inflammatory cytokines which are causing the inflammation. And here one can see the normal skin, the keratin layer well furnished, and epidermis and dermis, and here one can see the plaques on the keratin layer of the skin, and there is inflamed skin, and that is the characteristic of psoriasis as compared to the normal healthy skin. Here again one can see the histopathology of psoriasis. One can see the surface of the silver scale, and below that is the erythematous base, that is inflammatory base, and there is the persistence of the nuclei and microabscess here, and there is dilatation and the tortuosity of the papillary vessels, as one can see, and edema and the inflammation of the epidermis, dermis, and increased number of Langerhans cells have been seen also in the dermal layer of the skin. Now, pathophysiology continuing. These travel into the skin, causing the redness and the pus in the pustular lesion. Dilated blood vessels in the affected areas create warmth and redness in the skin layers, and the new skin cells move to the outermost layer of the skin too quickly, and that built up in thick scaly patches on the normal skin surface. So this movement is more than the normal cell movement. What causes the T cells to do this is still unclear. Perhaps genetic and the environmental factors are responsible. Abnormal production of the skin cells during the wound repair, and here the skin cells are replaced every 3 to 5 days in psoriasis, then usually which are being replaced in 28 to 30 days, and that is making the scale on the surface of the skin. Now, here one can see the scales on the surface of the skin, that is inflamed skin, and that is the keratin that one can compare with the normal. And here is the epidermis and the dermis and subcutaneous tissue. So the problems are here with this superficial layer of the skin. Now, what are the complications of the psoriasis? Number one is the psoriatic arthritis. It is seen in 30% cases a destructive arthritis that cause serious to permanent damage to the joint, and it can involve any joint, but mostly joints of the finger and the toes are involved, and so make sausage-shaped swelling of the fingers and the toes, which is called dactylitis. So that is dactylitis of the involvement of the fingers. When it affects the hips, knees and spine, it is called spondylitis, and in case of the sacroiliac joint involvement, it is called sacroiliitis. Now, the other complication is nail changes in fingers and the toenails. In 40 to 45% cases, there is pitting of the nail, pinhead size depression in the nails, a horizontal white or yellow margin at the tip of the nail is there, that is called distal onycholysis. Then loosening and separation of the nail away from the skin, which is called onycholysis. Now, here one can see the symptoms of the psoriatic arthritis, as one can see the normal and the affected joint. Similarly, there are the changes in the fingers in the nails, and one can see onychomycosis, nail pitting, and on X-ray finding, one can see the changes, and then there is arthritis mutilans, that is the D-shaping of the joints of the hand, and sometimes there is anterior uveitis is there. So one can see onycholysis, the changes of the nail pitting, subungual hyperkeratosis, and there is nail pitting, onychomycosis, and trichonychia, onychomycosis, and these are all the different nail changes which are seen in case of psoriasis. Then nail changes, there are small area of the bleeding from the capillaries under the nail. Nail is often yellow and crumbly. It is called oil drop or salmon drop spots. There is dryness, thickening of the skin under the nail, that is called subungual hyperkeratosis. That is the thickening of the skin, which is called hyperkeratosis. Then complication in cardiovascular disease, they have a higher risk of hypertension, arrhythmia, hyperlipidemia, heart disease, heart attacks, and stroke. Methotrexate provide protection for the heart, and the statins have also protective role in psoriasis. Then number 4 complication is metabolic syndrome. Psoriasis is associated with obesity, and the number of the new cases per year of type 2 diabetes, that is 27% more higher cases in case of psoriasis than in normal person. People gain weight because they are less active because of their psoriasis, and that is also one of the reasons of metabolic syndrome. So the patient with psoriasis do have obesity, non-alcoholic fatty liver, then hyperlipidemia, hypertension, and diabetes mellitus. I have already told you. The 5th complication is other autoimmune diseases, celiac disease, multiple sclerosis, inflammatory bowel disease like Crohn's disease, and ulcerative colitis are common with psoriasis. And 6th is complication is malignancy. There occur 2 types of the cancer. One is skin cancer, the other is non-skin cancer. Among the skin cancer, there is increased risk of squamous cell carcinoma, basal cell carcinoma, and non-melanoma skin cancer. And there is no increased risk of melanoma. Among the non-skin cancer, there is incidence of more of lymphoma, cancers of the lung and bronchial, cancer of the upper GIT, cancer of the urinary tract, liver, and the pancreatic cancer is there. And these are all blamed to be by the use of the methotrexate as the part of the systemic therapy. 7th complication is that these are the other complication, as these are less but more in the psoriasis patient. So these are eye condition like dry eyes, conjunctivitis, scleritis, keratitis, blepharitis, uveitis, glaucoma, and cataract. These are the eye condition and complication. Then other is Parkinson disease. A chronic neurological condition is seen more in psoriasis. Kidney disease, moderate to severe psoriasis has been seen in people with kidney disease, and emotional problem, that is psoriasis, do affect the quality of life, cause low self-esteem and depression, social withdrawal. Now one can see the dry eyes and scleritis, keratitis, uveitis, glaucoma, and cataract as the part of psoriasis, arthritis that can affect the eye, or there is the eye involvement in case of psoriasis.